It's my pleasure to be here virtually. I was hoping to be there in person and meet friends and colleagues from ESPID and Europe. But we make do with what the situation gives us. And it is nevertheless my privilege to be talking to you about this topic of infodemics and how they influence the work of those who are involved with infectious disease work, specifically pediatric infectious disease specialists. I don't have any disclosures. So let's start the story of this pandemic when there was only one case in the United States. I wrote this op-ed that had in the New York Times that had the title, "Is America Ready for Another Outbreak?" While it was written with the US in mind, with only one case confirmed, but really ominous signs on the horizon, it could have been written for any number of countries throughout the world, including in Europe. And there were three warnings in this op-ed. The first one was that in pandemic response, let the scientists lead, because otherwise people don't trust the messaging coming out of the government officials, and they do not comply. The second thing was that there should be no false assurances. And we have evidence from our previous large outbreaks that in the short run, people's anxiety does go down when you have false assurances, but in the long run, it's almost inevitably backfires. And the last thing I warned was about scientific and public misinformation. So we knew that we should expect the usual suspects to have all sorts of ideas circulate. We did not know the exact nature and content of it, but it wasn't a surprise when they happened. But there was another thing on the horizon that I warned about, and that included misinformation in the gray area, such as data shared through press releases, data shared through preprint servers that have a lot of utility to get the science out, but they can contribute to misinformation and an infodemic, which was brewing even in the early stages. But just to step back, we know that behaviors are contagious. All sorts of behaviors are contagious. This is a well-known graph and from a very interesting paper from one of my Yale colleagues, who's a physician and a sociologist, that showed that obesity, which is supposed to be a non-contagious disease, is spreading and does spread in social networks. So does misinformation. That also behaves like a contagious phenomenon. So an example from earlier on in this pandemic was this video called Plandemic, which had all sorts of misconceptions and conspiracy theories. And then it took off really quickly. And just to anchor what else was happening around that time in the US and throughout the world, the US Pentagon had confirmed a UFO, that it was a true UFO sighting. Imagine that if the US, someone would have asked me 5-10 years ago that a UFO sighting is confirmed by the US Pentagon as an unexplained phenomenon, an aerial phenomenon, and that's not the biggest story, and that's not the most lasting story for that week or that month, etc., I would have said, are you kidding me? But that happened. And regarding this pandemic, not only that there has been misinformation, but that misinformation has been contagious. And it is not just being shared through links on Facebook, etc. One big vulnerability we have in terms of social media or media that spreads very quickly is YouTube. We don't even think of YouTube often as a social media platform, but due to interactions, due to the ability to have longer lasting content. So the time it takes for a video to run means that the dose of misinformation is much higher than a tweet or a Facebook post, etc., makes it particularly concerning. And so this is an example from that vile and outlandish video that found a lot of audience through various means, including YouTube video. And we have seen that there have been data coming out on vaccines acceptance specifically, which is the biggest target of misinformation and disinformation. And it has come out, so this really nice survey um, that looked at 19 countries covering 55% of the global population, had 13,000 participants, was conducted in June 20, found that at that time, and this is before any of the products were out there, that approximately 71% of individuals would accept the vaccine in those countries, and accept the vaccine if recommended by employer was 48%. So there was an overlap and non-exclusivity in these groups, but just to say that there was signs that these vaccines wouldn't be universally acceptable. But I'll just give you I'll just alert you to the fact that even not all vaccine reluctance is outright anti-vaccine attitude. Some people have questions, etc., that can be addressed, and a lot of them are fence sitters. I and several colleagues had a survey in 10 LMICs, which had a sample size from, in each of these countries, in this case, 862 and 3,362 participants, so pretty wide-ranging but reasonably representative of those countries. And that was done between June and January 21, and that included, in addition to LMICs, Russia and the US. And what we found was that overall, the vaccine acceptance ranged from 67% to 97%. Average acceptance was 80%. So we have our work cut out for us for behavioral interventions to increase vaccine acceptance, which is our biggest tool for intervention in this pandemic. So there are several challenges in vaccine messaging. And just to think about vaccine behavior, it is a continuum. And WHO's SAGE and colleagues working on this problem through that came up with this model, this worldview that vaccine hesitancy is a continuum. On the one hand, there are people who are outright vaccine refusers, and that's a small group, fortunately. And on the other hand, there are people who are actively asking for vaccines, who have active demand. But there's a huge chunk of folks in the middle. And that includes passive acceptors who are not gung-ho about vaccines, but would accept it if it's easy enough. So that means making vaccines easy to accept works really well in that group. But then there are these fence-sitters or hesitant that accept some, delay some, or refuse some vaccines. And the reason why this is important is that this is a movable group, but they have questions. And you have to have persuasion interventions and other evidence-based interventions to address this. In terms of the active demand group, which is, here's what's happening in many countries. And by the time you hear this talk, there would have been more vaccines deployed in Europe as well. But there are early countries where the demand was really high. Not just in terms of the number of people. The group size was, fairly consistent and compatible with previous vaccines, but how vociferous they were, how eager they were, how vocal they were in the public sphere and the social media and all sorts of other locations. And so that created an impression that vaccine demand is not an issue. But if you look at it objectively, it is both supply and room for evidence-based interventions for sustaining demand for this vaccine against COVID-19. So when we think about increasing demand and looking at some of these interventions, it's one way to think about it is this concept of Russian dolls, that underlying everything are our values, ideology, identity, worldview. And then on top of that is trust, social norms, etc., experiences and fears. And on top of that are cognitive biases and attitudes. But what we often measure in usual surveys, etc., are thoughts and feelings and opinions. That's very surface. And some of my work that I will present has focused on some of these deeper aspects of our, of influencers of our behaviors. So vaccine hesitancy is complex, and we need to be cognizant of a lot of these features. So I'm going to take you through a series of experiments we have been doing with colleagues in around the world, and including in my own institution, where we have been trying to develop high quality evidence for interventions. So the first in this series was this experiment we did, taking advantage of an event that was coming up in the US, which was the presidential election. And there was a lot of concern, and that concern was shared across many countries regarding the approval process, whether there was political interference in the approval process or not. So this provided us an opportunity to randomize people into giving them situations, and this was done well before the election, and we asked them if the vaccine was approved or authorized a week before the election versus in December, or December 10th to be specifically, and the control condition was a week after the election. And we measured their projected uptake and confidence. And what we found was that if the vaccine had been authorized a week before the election, we would have had substantial lack of confidence in the vaccine. Since it was authorized after the election and was disconnected with the calendar, I think it did play a role in increasing confidence to a certain extent. We also did another experiment of what's so-called elite endorsement. Right now, so thinking about as infectious disease physicians, you should consider your role in the public sphere. And in the US, the director of the National Institute for Allergy and Infectious Diseases, Dr. Anthony Fauci, is the most prominent infectious disease physician. And we actually randomized him into the condition in terms of his endorsement. And this was all before authorization of the vaccine and even before phase 3 data coming out. And we found that if Dr. Fauci, Tony Fauci, had endorsed the vaccine negatively, if there had been a negative endorsement, so positive endorsement is that this person believes that the vaccine is safe and effective, and the negative statement is that they don't believe that this is safe and effective, or safe or effective. And in this kind of a situation, what we found was that a negative endorsement would have essentially doomed the vaccine. A positive endorsement would have and did help strengthening the confidence in this vaccine. What we also found that in the context of political leaders, if it was not bipartisan, if the President Trump and the Speaker of the House in the US was not endorsing it together, then their own single endorsement wasn't effective in either direction. So keeping in mind, in terms of the interventions, first of all, take your role as communicators seriously, because you are trusted, and trusted in the context of this pandemic. B, if you are in the position of influencing political leaders, make sure that the endorsement is bipartisan. We also tested a series of messages, and this was one trial where this was a screening trial where we screened initial messages, and then we replicated them in a confirmatory trial to have a concrete evidence of specific messaging around vaccines. And the way we thought about this is that there were two groups of intentions. First, intention to vaccinate, and the other one was other regarding outcomes. So whether you will advise a friend or judge a non-vaccinator. And I'll go through the different messages we tested out. And there are different behaviors like vaccinate in 3 months, vaccinate within a year, or either. And so we were looking at this, we were trying to filter out those who were initially hesitant, etc., or not. And this was again done in the fall. So the first message that showed promise was the not bravery message. It's a short version of it is that you're not brave if you don't get the COVID vaccine. The second one was economic freedom. That kind of didn't work, that each person who's vaccinated reduces the risk of lockdowns and losses of economic freedom. We did find in subsequent post hoc analysis that people who emphasize liberty, this works slightly better, but not as much. So it's important that a lot of our intuitions are not that valid in these kinds of situations. Trust in science initially worked, but did not pan out subsequently. Community interest. So getting COVID vaccine reduces the risk of spreading the disease to community and loved ones. Another one, interestingly and provocatively. So remember, not everything is ready for mass deployment, but it does teach us about what to do. It teaches us what can be the motivators that can be used to increase uptake. So one of the strong ones was um, uh, what we labeled as guilt, but it's a very subtle version of it, saying that getting COVID vaccine reduces the risk of spreading the deadly disease to others. So it's a other regarding outcome that you don't want to spread it to others. The other one was, a message that said, imagine how embarrassed will you be if you don't get the COVID vaccine and spread it to others. In a confirmatory trial, where we filtered it more and targeted it, what we found was that the non-bravery message, so the baseline info was a pretty information-only message that had some effect, but in terms of the content-based messages, the non-bravery message that you're not brave if you don't get the vaccine worked, both for self and other regarding outcomes. Trust in science didn't work for self-regarding, but was there for other regarding outcomes. So, again, our intuition, that's why we experiment. The community interest one, we're saying getting COVID vaccine reduces the risk of spreading the disease to community and loved ones, worked fairly effectively. But also community interest combined with, what we labeled as embarrassment, but it was pretty subtle. Imagine how embarrassed you will be if you don't get the COVID vaccine and spread it to others. So again, it riles up people when I discuss this. Not every medicine is for everyone. So it's a pretty strong medicine, and it should be targeted sparingly and judiciously. But you can imagine and leveraging this behavior rather than sort of shaming people into taking vaccine, which could be counterproductive. You can use that in a narrative that someone who doesn't feel, that has a regret if they give it to someone else, etc. So these kinds of things don't have to be deployed in every situation, but keeping in mind that there is value in testing out what is working and what is not working, and maybe weaving it into themes more subtly, for example, in a narrative format that is more subtle. There's a lot of discussion of vaccine mandates. This was back in June, July 2020, that where my group and others started talking about the possibility of mandate, not to take a position right away, but just to say that we knew that there will be considered as a policy option because it's too tempting. And the mandates can come in all sorts of shapes and sizes. Requirements is the other name for this. And all sorts of people have been discussing it for employers, for governments, and for events and all of that stuff. And we said that, look, mandates can work, but they should be used judiciously. They should not be draconian, and they should not disadvantage the underprivileged even more. But also, we identified in this paper in the New England Journal that there should be six criteria that entities should meet before they implement a mandate. First, the disease should be inadequately contained. So there's no justification. There's little justification for a mandate in an adequately contained outbreak. And we were talking about this pandemic. In the US context, it was ACIP, but generally speaking, the vaccine should be recommended by the recommending entity. So a public health entity should recommend. Authorization is not sufficient. There should be adequate supply of the vaccine. You don't want to exacerbate inequities by acting prematurely. There should be transparent communication. For example, the example about the AstraZeneca and vaccine and some of the adverse events associated with it was reasonably transparent in a lot of countries, and through EMA and through the FDA. And so that's an example of transparent, good faith communication. It's never perfect. It's always uncomfortable, but we owe it to folks if we're going to do any infectious disease policy, especially mandate. There should be infrastructure present for actual delivery of vaccine to every place, not just adequate supply, and then you should have evidence of inadequate voluntary response. Only then a mandate that doesn't disadvantage people should be considered. So why did we consider it in the first place? The thing is, whether we like it or not, policymakers have such incentives to do it, whether they're employers or certain governments, that they will consider it. But if we don't have checks and balances on this, it will be a half-baked, and poorly implemented mandate or policy. So switching to misinformation management more directly. So this is a tool we developed at Yale with UNICEF, with organizations called PGP and First Draft in collaboration to come up with a field guide in various places for policymakers in the clinic and various other various other entities in between to synthesize evidence-based approaches for misinformation management. Just to go through certain definitions, that you have information, which means data with meaning. You have rumors, which is unverified information. And misinformation technically is accidental falsehood, and disinformation is intentional falsehood. However, often people use misinformation to encompass disinformation as well. So keeping that in mind, this is one way of approaching it. So we should be ready. Organizations should be ready. Entities should be ready. And at some level, individual groups of physicians should be ready. And other healthcare providers should be ready with to respond to falsehoods, intentional or unintentional. There should be a listening system. There are a lot of tools. They're not available to individuals, but they are available to organizations for social listening, and they are now inexpensive. Understand, assess misinformation. If there is capability to have analytics and intelligence around this, and pay attention to the literature. Engage, and the engagement should be strategic engagement, and this should be cyclical. And so there are certain questions to ask at various levels. Would a response actually give oxygen to the misinformation? What happens if nothing is done? Are there other facts or events that you should wait for to come out? So for example, some people jumped on the risk benefit, in my perspective, around the clotting events and the AstraZeneca vaccine a little too early. The risk benefit got clarified very quickly. That was the time to go after it. What is the reach and scope of misinformation? What is the likelihood of spread or escalation? Could it erode general trust in vaccination or specific vaccine? So if you give it more oxygen, could it have that result? And what is your capacity to respond? So we provide this risk evaluation metrics that has these indicators in these on this side, and then in various columns we have low, medium, high risk. And the idea is to think through these things systematically and figure out what is the risk in terms of vaccine hesitancy and demand, reach and scope of misinformation, likelihood of issue spread or escalation, response capacity, general public trust, and the ability to and the response itself. So in this guide, we provide this approach to acting in terms of deciding when to engage. And this starts with social listening that can be formal or informal, but it has to be more systematic if you're a public health entity or you're advising a leadership entity. But even as individuals, there are ways of social listening, as I mentioned earlier. And the idea is to stratify what is the situation you're dealing with. If there are information gaps, then help shape the agenda. If there is misinformation based on the matrix that I described early, which is low risk, inoculate and pre-bunk. And I'll talk about pre-bunking and debunking in a second, and monitor closely. If there's misinformation, medium to high risk, then debunk specific myths. So think about, you don't have to engage every time with direct misinformation. So the way to inoculate and often respond to this, misinformation and disinformation, is not to start with the fallacy. So often, we develop these fact sheets for hospitals and other entities, and even for our own communication, that start with the myth. That's a bad way to start. You don't want to increase the salience of the myth itself, because people remember then the myth and not the fact. So start with the fact, make it clear, relevant, sticky. Then give a warning that there is misinformation coming, that some people think. So the fact is that vaccines do not modify your DNA. Then the warning is that some people believe that your DNA is modified irrevocably buy these vaccines, or whatever phrasing they use, and then warn that. And so say some people falsely believe, to be precise. So have a warning that it's a myth, that it's false upfront. Then come to the fallacy, say you can have the tactics being used to deceive, highlight the misleading tactics, and sometimes reveal the agenda. And then follow it up with the fact that provide alternative correct info. Give them why some people think that must replace misinformation cannot leave a vacuum, and make correct information more attractive and stickier. Give them a folksy example. Explain it so well that people remember it, and so on and so forth. If you have tools available, make the graphics high quality, and so on and so forth. Another way of looking at it is speaking to people's values. And so a lot of my work has focused on this. And think of, there is an approach to thinking about this called moral foundations theory that came from social psychology. And that postulates that, like our taste buds, our real taste buds, where we have now 5 known taste flavors, bitter, salty, sweet, umami, and sour, the permutation of stimulation of these taste buds gives us this the distinctive taste of a type of food, etc., of a dish, and so on and so forth. But also our underlying sensitivity also varies to these kinds of stimuli based on various factors. So it turns out we wanted to explore that these 6 moral taste buds play a role or not. And so the part of the theory is that all humans have, just like other taste buds, 6 moral taste buds, and they're triggered differentially by different messages, and people have different underlying sensitivity of these values based on their ideology, based on culture, and based on individual level factors. So the most constant one, the most hardwired one, is care harm. That's why we want to protect people. Fairness, cheating, the golden rule, for example. Loyalty, betrayal, we root for our teams. Authority, subversion. That includes submission to physician authority, etc., but also all sorts of authority. Purity, degradation, that can be religious or secular. And liberty, oppression, that can manifest as the positive framing liberty, and the negative framing oppression, etc. So these are the values that are constant to us, but they are differentially emphasized in different people and different populations. So we did this study, and we said, in terms of high versus low hesitancy parents, what was the evidence of these being vaccine decisions being, or vaccine perceptions being, moral decisions and perceptions? So first thing we found was that folks who emphasized authority, had more deference to authority, were less hesitant. So that's a point of intervention. And there's a reason why healthcare providers, specifically physicians, are considered the most trusted source of vaccine information, even amongst those who refuse vaccines. Then the second one was purity, but it went in the other direction. So those who emphasized purity were more on the hesitant side, and those who emphasized liberty were also on the hesitant side. And so there are numerous, a lot of friends and colleagues around the world know of this work that we have been doing, the series of work that we have been doing. And many of them texted me or emailed me during the pandemic based on protests, etc., even during the mass protests, but also as vaccines became a reality, saying that how, remarking on the fact that we were focusing on liberty, because a lot of discussion was around liberty, some in around purity in these opposition to vaccines, etc. And the idea is that these are underlying values. Our job is not to change people's values, but our job is to speak to people's values. So we did this initial experiment for purity and HPV vaccines, and this was going on as the pandemic started, etc. We analyzed around that time, and we found that purity, and discussed the negative side of purity. We did this randomized trial in young adults in the US and showed them genital warts, and with a vignette talking about how disgusting can be to influencing their purity violation. And the hypothesis was that young adults, there is evidence, have this thing called present bias, in the sense that they don't think of cancer They think they're invincible. So these are the people who didn't get vaccines in their teenage years. And what we found that in terms of the intervention, there was a approximately 20 percentage point difference in terms of reporting that they're likely to get an HPV vaccine in the next 6 months after that intervention. We are now doing experiments around the liberty value and more directly for COVID-19. And maybe by the time you hear this lecture or this talk, our experiment is likely to be done. And so you can look it up in terms of what we found. The other thing is the prominence of social media, especially when people are socially distanced. They're engaging with each other increasingly and more exclusively through social media. And so we partnered again with UNICEF and Facebook and developed this vaccine messaging guide generally with social media in mind, because it had collaboration with Facebook, but it is for broad intervention, et cetera, and you can sort of look it up and obtain it. We are also doing a specific project in 5 countries with Facebook, leveraging their own abilities and insights, et cetera, to leverage insights to act and then measure impact in actual coverage. So this will be the first study where we will test initial sets of messages just based on their intention to vaccinate, but then we'll find the best messages that will and measure their impact on actual coverage of vaccines. And this is being done in 5 countries, including Europe. And then I had the privilege of being part of the WHO, newly formed WHO technical advisory groups on behavioral insights, which had its first task to come up with a broader, not just in terms of persuasion, but broader behavioral considerations for acceptance and uptake of COVID-19 vaccines. And we had 3 prongs that we came up with. And so these are behavioral scientists from vaccines and non-vaccines, or interdisciplinary group of scientists. So and including people like myself. We came up with 3 prongs. And the first thing is, vaccine acceptance doesn't start with persuasion. It starts with creating an enabling environment. How easy it is to get a vaccine, how appealing the environment is, and so on and so forth. Then harnessing social influences, meaning emphasizing social norms, saying, especially physicians emphasizing that it's a norm for you to get this vaccine. Other healthcare workers emphasizing these vaccines being a social norm, and then increasing motivation through an open and transparent dialogue and communication about uncertainty of risk, including around safety and benefits of vaccination. So that's a bigger picture. And so I was thinking about this and say, what is the role of those of us who focus on infectious diseases, be it epidemiologists, be it adult or pediatric infectious disease physicians, or others who are engaged with contagions and infectious diseases. And I've been saying this around this about universities, and I think it holds true for these kinds of professions that will be dealing with infectious diseases, even after it ceases to be the coolest thing around, where everyone seems to be an expert on outbreaks and pandemics. When all of that dust settles down, we will be around. And just like universities have a privileged positions in societies and civilizations, these professions, those of us who focus on pandemics and infectious diseases, have a privileged positions in societies, because we are guardians of knowledge for future generations. Because this event will repeat, but not next year necessarily. And so this longevity of understanding and knowledge is our responsibility. What we are learning now through science, through experience, through policy, we have to, and we will pass to our students, our mentees, our future scientists, future physicians, future nurses, and future epidemiologists, etc. I'll pause here. It's been a great pleasure talking about some of the things we and others have been working, and hopefully this conversation will continue and will be productive. So in the end, as I thank you, I want to make a request that we should demand the same level of rigor in vaccine acceptance science and use the same evidence-based tool from vaccine acceptance science as we do from vaccine development science. So I hope you stay engaged with the process. I hope you continue to seek evidence-based tools. And I often share it on my Twitter feed. There are many other sources out there. Feel free to search and engage and obtain these sources. Thank you.